by Professor Arman. Professor Arman was heavily involved in directing the management of the patient we are about to present today. Professor Arman was a consultant in USM Masters of Plastic Surgery Training, and recently, 2 years ago, he was in MSU MC Shah Alam, and UKM has engaged him as a visiting consultant on reconstructive cases. So let's give a warm welcome to Professor Arman Zaharil Saad.
Thank you, Adzim. Welcome everybody. Assalamualaikum and very good morning. Okay, today we're gonna discuss about one very interesting case that involves a multidisciplinary team in the UKM. So the title of this presentation today is Salvaging the Unsalvagable. Okay, we have 4 very good speakers or presenters. First one will be Dr. Nur Fatin Najlaa, and then followed by Dr. Siti Muyassarah, and then Dr. Parminder Singh before Dr. Muyassarah, and then last will be discussed by Dr. Adzim. Okay, without further ado, because I think we are trying to be on time for every to complete this CPC, I would like to invite Dr. Nur Fatin Najlaa to present the case history or case that we are gonna discuss today. So please welcome Dr. Nur Fatin to talk about the case.
My name is Fatin. I'll be presenting on the case history presentation, Salvaging the Unsalvageable. So this patient is Mr. T, a 6 years old Malay gentleman with no medical illness. He presented with an alleged MVA on the 1st of September 2020, around 1 a.m. at McNaught Highway. Patient was a lorry driver, skidded on the right side, and patient was trapped in the lorry. Unsure duration of trap. Apparently there was another passenger got out from this lorry and disappeared while the first responder trying to extricate the patient. The mechanism of injury was unknown, and patient was brought in by the ambulance call. Subsequently, patient sustained a degloving wound over the right upper limb, extending from the right anterior shoulder until the right wrist and right thumb. And there was a pain over the wound site. Patient was unable to move the whole right limb, including the fingers, which is associated with numbness over the whole right upper limb. There's also a laceration wound over the scalp, and patient was unsure of loss of consciousness or retrograde amnesia, otherwise no abdominal pain or no chest pain. In ED, after given ketamine, GCS dropped, saturation dropped until 76%, and patient was intubated for airway protection. Hence, on examination, upon arrival, patient was agitated, restless, speak in phrases, no drooling, audible wheeze, upper limb immobilization applied onto the right and left upper limb, on cervical collar and long spinal cord. The airway was patent, no drooling, tracheal was central, no deviation, no crepitus. Breathing, there's no anterior neck swelling, no distended veins, no crepitus, equal chest expansion, no chest tenderness, no subcutaneous emphysema, there's right clavicle fracture. Otherwise, the lung that's also noted to be reduced at entry over the right upper zone. On SpO2 to unhealthy mass was more than 90%. Subsequently, was dropped and patient was intubated. Disability noted that GCS upon arrival was 11/15. Post-intubation was 3/15. Pupils were 3 mm reactive, bilaterally, no lateralizing sign. Exposure, degloving wound noted over the anterior aspect of the right shoulder until the distal forearm, about 50 times 50 centimeter. Laceration wound at the tena eminensis, about 3 centimeter times 3 centimeter. Tissue loss at the right cubital fossa, bone were exposed, transected brachial artery proximal to the cubital fossa with segment loss. There's also right radial pulse and ulna was not palpable. No signal of Doppler. Motor sensation loss, mostly at the median nerve. Mass score at that time was 8. Degloving wound 5 times 5 centimeter at the right scalp bone that were exposed. Otherwise, radiological examination, chest X-ray was not that significant. ETD was in situ, no hemo or pneumothorax seen, no rib fracture seen. Pelvic X-ray, there's no fracture seen. The X-ray of the upper limb noted there's a skid irregularity seen involving the right upper arm and the right antecubital fossa region, likely to represent the degloving injury. Multiple opacities of varying sizes seen at the right arm and forearm, likely to represent a foreign body, glass pieces. Otherwise, no fracture or dislocation, preserved joint spaces. CT brain, there's no ICB or midline shift. CT brain bone window noted to have right frontal outer table fracture, right parietal outer and inner table fracture. Otherwise, CT cervical noted to have C5 anterior vertebral body chip fracture. Blood investigation, full blood count was the only thing that was abnormal was white cell count, which was 18.2. Coagulation profile was normal. RP noted as an AKI with a potassium of 3.3 and creatinine of 148. CK on admission was 360. Diagnosis were made, which was mangled right upper limb, left upper limb laceration wound with skin loss, frontal parietal bone fracture, and C4 and C5 fracture. Immediate referrals were made to the neurosurgery, which was conservative, vascular in view of mass score of 8. There's no active intervention, hence the referral to General Ortho on call, and General Ortho seen the patient and discussed with the hand team for opinion, not for amputation of the right upper limb, for reassessment in OT, and plastic team was referred as well for soft tissue coverage and limb reconstruction on day 3.
Okay, thank you, Fatin. Now I would like to invite Dr. Parminder to give his input regarding this case because he's seen this patient before it was referred to the plastic surgical team.
Hi, good morning, everyone, and the panelists. Okay, I'm Parminder. Okay, I was actually referred this case to early morning after the seen by the several teams, and they wanted opinion whether is it salvageable or not. On arrival, actually, when I saw the radial pulse, ulnar pulse actually were not palpable, and on the wound there was a large wound, and from the shoulder, the deltoid muscle, the brachial over the brachial area, brachial artery area, medial side of the elbow, there was actually a hematoma with a transected brachial artery up to the cubital fossa, where the bifurcation of the radial and the ulnar artery were there, and it was also thrombosed proximally and distally. There were no active bleeders at that time, but the SpO2 of the right upper limb was unable to get, but the finger capillary field was still within 2 seconds at that time. So the sensory also was present for the ulnar and the radial side, only lost for the median nerve distribution, where the median nerve was also transected and lost at the cubital fossa region. So that really shows the sensory was lost. So there was no actually general paresthesia of the right upper limb. And in view of those features which I saw, I decided to go in and debride first and have a look whether the muscle is contractile and all, because at certain points of the muscle beneath the hematoma, the muscles were still contractile and over the forearm. So that also made me a decision. So we go in and see how it is it salvageable or not? And then from there, we may proceed later on. And we did not plan to amputate in the same setting also. We thought once it's a bit more stabilized, and if the thing doesn't survive, then we may amputate later. And luckily, after first debridement, after that he went to the ICU and he came out. Then we took him for a second debridement for the second look, and then after that time we referred him to the plastic team for wound coverage and the bone coverage around the cubital fossa, as there were also findings where the bicep tendon insertion point was lost over the cubital fossa. So the elbow flexion was not there, the joint was exposed, the bone was exposed over the distal humerus, and also joint. There was some instability, but we plicated the medial collateral ligaments of the joint to stabilize it. And then plastic saw the patient the subsequent debridement. Thanks,
okay, thank you, Parminder. Okay, next I would like to invite Dr. Muya to to discuss the management of this very complex case. As you can see, he lost a lot of structures, including the vessel and the nerve that's supplying the hand, and also he also has a loss of functional flexion of the elbow. So I'd like to welcome Dr. Siti Muyassarah to present the management of this case.
Thank you,
Okay.
Prof. Arman. As Dr. Parminder mentioned just now, ortho hand did a wound debridement of the right upper limb and structural repair of a dorsum of left hand and left ring finger on the 1st of September. And these are the close-up of the wound after the first debridement. And 2 days later, a second look was done. We get a clearer picture of the soft tissue defect. Proximally here, shown in the video, is the brachial artery that was transected and was ligated. And adjacent to it is the median nerve that is also transected with a 10 centimeter segment loss. And distally, the radial and ulnar artery was transected with a loss of bifurcation and was also ligated. And shown here is a critical area defect with a 15 times 20 centimeter size. And the total soft tissue defect was 50 centimeter times 15 centimeter. So this is what it looks like after the second wound debridement. And for a temporary coverage, we decided to put allograft. Here are the videos how we put the allograft, which was taken from our previous donors. And we bandage the allograft with dressing Acticoat, dry gauze, and also crepe bandage. For definitive coverage, it was done on the 11th of September. After a final third wound debridement by ortho team, we proceeded with the functional pedicle latissimus dorsi flap, together with brachial artery revascularization, saphenous nerve graft for median nerve of the right upper limb. So the latissimus dorsi flap was harvested in a lateral position, and its pedicle was identified and preserved, which is the thoracodorsal artery with the thoracodorsal nerve. In the same setting, a sural nerve and the lesser saphenous vein was harvested from the right leg by another surgeon. The length of the harvested nerve and vessel was 30 centimeter. And the sural nerve was used as a vascularized nerve graft to neurotize the median nerve, and the lesser saphenous vein is used as a vein graft to bridge between the right brachial artery to the right radial artery. And the critical area that is exposing all the vessels and the nerves are covered with the muscle as a functional muscle flap, and the remaining of non-critical area, which is the raw area but does not expose any vessels or nerve, are covered with split skin graft. Shown here is on the left photo is the proximal stump, which is the brachial artery and the median nerve. And the middle photo is the radial artery, and the right photo is the ulnar artery. This is how we plan for latissimus dorsi flap. Patient is put in the lateral position, and on the right side is the sural nerve graft and the lesser saphenous vein that was harvested. And over here, shown here is anastomosis of the lesser saphenous vein graft proximally to the brachial artery and distally to the radial artery. Can see here is the pulsation of the saphenous vein graft after the anastomosis. A closer photo of the anastomosis site. And this is how harvested pedicle latissimus dorsi looks like. Before we transpose it, we created a tunnel through the axilla and brought the pedicle latissimus dorsi to the soft tissue defect. And this is how it looks like, the position after the transposition of latissimus dorsi flap via the axillary tunnel. And we placated and molded the flap to cover the critical area and also as a functional muscle substitute. And the rest, on the right side, you can see the split skin graft, which was applied for the rest of the non-critical area. For dressings, we dress the flap side with the bactigras and gauze. And for the SSG side, we dress with bactigras, flavin cotton, and dry gauze. We bandaged with a non-compressive bandage and created a window to the flap for flap monitoring. And we immobilized the whole upper limb with a POP. Post-operatively, we monitor the flap for 1-2 days, 2-hourly flap monitoring. For 3 to 5 days later, we monitor about 4-hourly. How we monitor the flap is we monitor via the color, temperature, capillary refill time, and pulses. Here is the Doppler flap monitoring. You can see the capillary refill time here. And post-operative, it was uneventful, but a minor procedure was done for wound debridement and secondary suturing of the right upper limb on the 21st, and also a split skin graft of the right upper limb as a final touch. Patient was discharged on day 46 post-trauma. This is a video of the patient 10 months post-operative with hand rehabilitation. The sensation was returned with a gross touch of score 3/10, about 30%. As you can see, the function of tena muscles are almost full, as well as the flexion elbow is quite strong. And that's our management.
All right, next I would like to invite Dr. Adzim to do a general discussion about the overall management of the case and also the background of some of the procedure and scoring system that have been used to manage these cases. Adzim, screen is yours.
Thank you very much, Prof. Arman. Thank you to my colleagues who have presented before. So, to kickstart the discussion, I would like to start with the scoring which we used initially. So I would like to bring us back to a bit of history. Decades ago, for trauma surgeons, limb trauma surgeons, they were in a constant dilemma in terms of should a limb be salvaged, a limb which has undergone a high energy injury with severe tissue loss. Should it be salvaged or should it be amputated? Because if it was if they attempt to salvage it too much and patient ends up with an amputation anyway, there's a lot of loss of time for the patient and also for the hospital side, and end up with an amputation anyway. On the other hand, as trauma surgeons, everyone is always keen to preserve as much as they can. So to answer this, Johansson et al. In 1990 came up with the MAS score. He published this. It was based on 4 criteria at the time, whether there's the severity of the skeletal or soft tissue injury, whether there's limb ischemia in terms of pulses and also cap refill, whether there was presence of shock, whether the shock was transient or whether it's prolonged, and of course the age. And he came up, I'm not going to go into details of how it's scored, but a score of 7 or greater is usually favorable for amputation, according to his finding. And our patient, as you know, had 8. So it was indeed indicated initially. And however, trauma surgeons all over who applied this MAS score, some of them found contradicting clinical findings. So a debate went on for a more definitive criteria. Next, please. So to answer this dilemma, the LEAP study group was formed. The LEAP study group is a lower extremity assessment project which was formed around 2000-2001. And it was a large group in which finally in 2010, Higgins et al. Came up with a major publication. It was a multi-center assessment at 8 level 1 trauma centers in America. There they applied the MAS score, the limb salvage index score, the predictive salvage index score, and NISA score to see the utilization and whether it predicts well. And true enough, they did demonstrate high specificity in the scores, 87 to 97%. What this means is, with high specificity, this ensures that there's minimal number of salvageable limbs which were finally amputated. It did show a low sensitivity of 46%, and this means that what sensitivity means is it guards against delay in amputation for unsalvageable limbs. But however, in this publication also, they concluded that they could not validate the clinical utility of any scoring system. And they advised for cautious application of the scoring system. And until to date, there's no definite criteria for amputation. And you have to bear in mind that these scoring systems are mainly for open tibial injuries. Okay, next. So once we were we seeing eye to eye with the hand team in terms of the intention to reconstruct or salvage this limb, we had to come up with our reconstructive strategy objectives. And number one, we needed a wound bed that is clear from any necrotic or contaminated tissue. Number two, we wanted to restore the neurovascularity of the main vessel. So specifically in this case was the brachial artery. So the brachial artery was avulsed totally all the way to the bifurcation. And following that, after repairing all this, we needed a durable soft tissue coverage to cover all these fragile repairs. We also intend to restore some functionality because his median nerve was injured, and there was also loss of flexion of elbow, and all this should promote healing in the most rapid time frame. Next, please. So how we executed it was, number one, we had a multidisciplinary approach. So it was between the hand orthopedic and plastic surgery teams. So the wound was debrided to healthy edges and bases. The blood vessels and nerves were trimmed to healthy levels too. And we started to restore the blood supply of main upper limb trunk, the brachial artery to the radial artery. We also perform a nerve graft using the vascularized sural nerve. And this was to neurotize the median nerve. Following that, we, as explained by my colleague just now, we use the latissimus dorsi flap as a soft tissue coverage, and this protected the vital repairs and covers the wound surface one go. And also, unique to this case, we managed to make it also a functional coverage in which we preserve the motor nerve to the muscle, allowing it to flex and replace the biceps function or the elbow flexion. Next, please. So I would like to walk through the audience in how we, what tools we use for our decision making in reconstruction. So the new reconstructive ladder was modified in 2011. Actually, the reconstructive ladder has been a very useful tool for reconstructive surgeons. And it was created many decades ago. It has undergone a few refining, especially with advent of new technology and such. And this was the latest one in 2011, published in the PRS by Jeffrey Janis. Next, please. So this is what the ladder looks like. So this ladder is many tiers, many stepwise approach from the least complex to the most complex. Right, from we start at the lowest rung as the primary closure, then closure by secondary intention, the negative wound therapy. So in this particular case, these three low level reconstructions would have not been feasible. The patient would have been rendered with a chronic wound, And following that, there's skin graft, dermal matrix, and this would have covered the wound, but however, it would not have returned the vascularity to the distal end of the hand. And for local flaps, it was not feasible in this case because it was such a large wound. So we were left with the option of distant flaps and free flaps. We could not use tissue expansion too because there's no adjacent tissue. So we, in considering these two options, distant flaps and free flaps, which are the highest rung of the reconstruction. Okay, next please. In considering those two options, we have these two considerations, whether we want to use a fasciocutaneous flap or a musculocutaneous flap. So you can see the fasciocutaneous flap is skin or with subcutaneous fat and the deep fascia, and the musculocutaneous flap also about the same component, but we add on muscle, and we can see that the fasciocutaneous flap, without having an underlying muscle, you can see that there's smaller vessels which you have to dissect compared to the musculocutaneous flap, where there's only one large source vessel which you have to dissect. Okay, next please. So to choose this also, there's been a lot of discussion on which one is better, muscle or fasciocutaneous flaps in any reconstruction actually. And these few papers, next please. These few papers, they have been trying to outline which one is better, and I have digested the information here and made it into a more presentable form. Next please. So what's the advantage and disadvantage of both? So I'll go one by one. For fasciocutaneous flap, there is better functional preservation for the donor, and on the opposite side, for musculocutaneous, the donor function will be affected because we're going to remove muscle. Muscle is important for movement, and therefore the patient might need to relearn some movement or might need to use his remaining other muscles to adapt to this loss of function. For the fasciocutaneous flap, it's also easier to re-elevate in case wound breakdown happens, and wound breakdown is not uncommon to happen in a reconstructive surgery. As opposed to musculocutaneous flap, if we were to re-elevate this flap, let's say there's a wound breakdown, this, because of the nature of how the muscle heals in a fibrotic form, it might actually cause flap necrosis instead when we re-elevate. So for fasciocutaneous also, it can be potentially sensate if we included sensory nerve neurotization. On the opposite side, for musculocutaneous, usually it's not. It cannot be sensate. Will only the return of sensation will usually only be deep sensation, which is non-discriminative. And but however, muscle flaps has potential for functional transfer. That means we can, like in this case, it can return back the movement function. Okay. Next, again, in the fasciocutaneous, usually this needs prolonged dissection. As I demonstrated in the image early on, there's more of small vessels to be dealt with, to be given attention. And there's usually high variability of the vascular pedicle. This is usually needs more experienced surgeons. And on the musculocutaneous side, usually there's not much of variability. We carry on all the small vessels in the muscle, and therefore we just need to deal with one vascular pedicle which is larger. And therefore, it's theoretically more rapid dissection. And usually, this is also the type of flap which is used for training for the junior trainees of plastic surgery. Okay, on the fasciocutaneous side, usually fasciocutaneous flaps are raised as free flaps, and usually we will need microsurgery expertise. And with microsurgery, there comes a lot of post-op care. Just now, Ms. Muya already demonstrated the amount of post-op care we had to give to the patient, but in microsurgery, it's way more than that. It's more concentrated, more focused, and more intense. And however, in musculocutaneous side, particularly in this case, we did not need any microsurgery. And muscle flaps have traditionally been preferred for those which are deemed contaminated surface, because of the action of so-called muscle macrophage. Next, please. Okay, fasciocutaneous flaps are also seen to be aesthetically superior because there's lack of scars, as opposed to musculocutaneous, which usually thins over time and it will conform over surfaces, but the surfaces are usually more of a fibrotic surface. And in fasciocutaneous, usually we do not need much of grafting. If there's any needed, any grafting needed, it will be usually limited, as opposed to musculocutaneous flap. Usually we have to graft it. So having considered all that, and we went ahead with the latissimus dorsi flap, I would like to describe a bit about this latissimus dorsi flap, which is actually I think quite common nowadays among the surgeons. Not only plastic surgeons use it. I think orthopedics, breast surgeons also quite familiar with it. So it was first introduced by Tansini in 1906 for a mastectomy defect, but it was subsequently forgotten because mastectomy practices of that time was evolving to primary closure. And subsequently was reintroduced by Olivari in 1976 for chest wall wounds, ulcerations. And Bostwick in 1978 used it for breast reconstruction. This flap can be elevated based on its pedicle, as in our case, or we can raise it as a free flap. It can be a muscle flap, it can be a musculocutaneous flap, like in our case, it's a musculocutaneous flap because of the skin island, or it can be an osteomyocutaneous flap. You can carry a bit of the rib bone. Okay, next please. So some anatomy of the latissimus dorsi flap. This for maybe some revision also for the medical students. The origin of it is from T7 and lower thoracic vertebra and corresponding ribs, the lumbosacral spinal process, the thoracolumbar fascia, the posterior and middle outer rim of iliac crest. And it usually inserts in the floor of the bicipital groove. And I think we remember the mnemonic, the lady between two majors, right? Okay. So the blood supply, this is of most important concern for us reconstructive surgeon, because we really need to preserve blood supply. And so it's well studied that the blood supply comes from, there's dual blood supply. Number one is the many posterior intercostal perforators, and of interest is the thoracodorsal artery, which is what we based our flap on. We detached the posterior intercostal perforator so that it could be mobilized, and we totally relied and let this muscle rely on the feeding of the thoracodorsal artery. Thoracodorsal artery in turn is a branch of the subscapular artery, which is a part from the third part of axillary artery. The innervation is from thoracodorsal nerve, which is from the posterior cord of brachial plexus, and also again we preserve this so that we could have the motor function as we demonstrated in this case just now. Next, please. Okay, what are the advantages of this flap? It has a very reliable blood supply. Okay, even though we detach all these posterior intercostal perforators as seen in this picture, even though we detach that, it is well nourished, even though there's only one artery from the thoracodorsal artery. The dissection is quite rapid because you just need to detect the plane and just clear it off from the origins. In this picture that we showed a skin island, small skin island, and this can be orientated either vertically or obliquely. In our case, if you remember, it was a bigger skin island which we used. This flap can also be tailored to any size and shape, and is also one of the largest flaps in the body, and it's very versatile. We can close large defects and also small defects. Okay, next. So the disadvantage is it might be a bit too bulky, and since it's a muscle, there might be some retained functional deficit with the patient, and this is reported to be about 7% in the literature. And however, a lot of patients rarely notice it, and it may cause some winging of scapula, and it may compromise posterior push, especially in swimming and skiing. Patients usually can swim. However, if a patient is maybe an athlete a swimming athlete who relies heavily on his swimming, this might compromise his function in getting better performance. And this functional deficit may be more prominent in paraplegics who rely a lot on the upper limb strength. And another disadvantage is there may be pain at donor site, which might be a bit prolonged. So in conclusion, the scoring system for limb amputation versus salvaging is to be used only as a guide, and it is to be used cautiously. In complex limb injuries, a multidisciplinary approach is the best. The reconstructive ladder is a useful tool for reconstructive surgeons to approach a specific problem, and patients may undergo a long-term management for rehabilitation and monitoring. And with that, I end my presentation. Thank you.
Thank you, Adzim. That was a very comprehensive discussion on the topic and the case that you have managed successfully with your colleague in last year. Okay, since we have plenty of time, and I think only if there's anybody in the audience who would like to ask any question to our speaker.
Prof. Arman, there's a question in the Q&A session box.
Oh, all right, okay. Right. Let's see. Hi, can we consider the use of skin substitute in cases like this? Okay, is skin substitute used in the practice for skin loss in HTCM? Okay, any of, I think it's open to any of our speakers, Adzim or Muya, if you would like to answer that question.
Okay, since it was part of my presentation, if we look at the reconstructive ladder, it is definitely an option. However, I stated just now that if we did this, that means there won't be restoration of the distal vessel, and we cannot put a skin substitute over a vessel. It's usually less ideal. It might render the vessel to injury in the future. And also bearing in mind the amount of tissue defect, I don't think our skin substitutes can be adequate to cover this. Thank you.
Okay, there's another question from Muhammad Ashik. What is the criteria for skin allograft compatibility? Probably like back grouping. Any of you would like to comment? Maybe Adzim again, since you are fellow in the skin substitute or skin engineering committee.
Okay, so the use of allograft, allograft has been traditionally used for temporary coverage. Okay, usually it will reject eventually. The reason why my colleague used it initially was to protect whatever vessels there was, and also somewhat to test the wound bed to see whether the wound bed is ready for us. It shows whether the wound bed is less contaminated now and kind of ready to be deconstructed now. And to use allograft as a permanent solution is not ideal in this scenario. Thank you.
Okay, we have next questions. Is there any other skin flap besides lactoside that can be used in such case? Thank you. Maybe Muya, you can answer this question.
Hi. So there are other options. Actually, we can use other parts of our body. For example, our anterolateral thigh flap. Basically, we choose the flap based on what is feasible for the surgeon. That can save time and also fulfill the criteria that we want. In this case, it has both vascularity and also the nerve that we want to use as a functional pedicle muscle flap.
Okay, if I may add a few more advantages of lead dosai in this case, because it lends itself well for the defect actually, it's nearby and then it has a large tissue coverage. If we take from other places, I think it will be a microvascular free tissue transfer, which added 1 or 2 hours to the surgical time for anastomosis and also to inside the flap. But lead dosai in this case is just sitting there begging to be used. As well as it has the large coverage of the surface area. It also has additional benefit, which is the functional. It can do with the preservation of the nerve. It can be used as a functional reconstruction for the assisting in elbow flexions. Yeah. Okay, is there any more question? Let me browse through. Any more questions? Okay, any other data on the tissue engineering regenerative for skin loss, the use of biomaterial or stem cell for replacement therapy in severe skin trauma? Okay, I think maybe to Adzim again. Adzim, any data on tissue engineering or regenerative for skin loss, the use of biomaterial or stem cell for replacement therapy in severe skin trauma?
I think that to answer this, this is an ongoing study still in terms of how efficient the skin loss can be managed by for the skin loss using any tissue engineering or regenerative. So part of it is with this new dermal matrix, which the one which is popular now is Integra, which we can use to cover and so-called be a dermal scaffold to create a new dermis. And this is usually a two-stage process in which first we need the dermal regeneration template followed by a skin graft to epithelialize over. To the use of stem cell therapy, yes, this is also I think in the more recent publications there's more promising findings in terms of usage of stem cell for basically to help regenerate the new epidermis, new dermis. It might, from our little experience, it does take longer, and for this particular case, again, it does not fulfill our objectives in this particular patient.
Okay, thank you, Adzim.
Yeah, okay. However, there is, of course, there's future ongoing more researchers, and hopefully we reach a better level of advancement in this, in terms of more complex wounds such as this.
Okay. So, if I may add again, I think for the use of biomaterial or stem cell for replacement therapy in severe skin trauma, normally I think is more focused on the severe burn injury, where the large amount of total body surface area of skin are lost in the case. But in other trauma, I think the function of this new technology, I think is probably quite limited unless it's only involve the skin surface area. Okay, so we go next to the next question. Okay, great presentation and awesome effort to preserve the limb for the patient. Okay, thank you very much. If this patient presented to a district hospital or hospital without reconstructive support, how should we initially manage this limb before referring to a tertiary center instead of amputation? Okay, probably this time I'll give it to Dr. Moya.
Okay. So if in a tertiary center, the most vital part of the in the view of reconstructive is the blood supply of the remaining tissues. So after hemostasis is being done, and also some minor wound debridement that can be done in the tertiary center, it should be referred to the ortho team first. And for the dressing, perhaps if it's if you can use something with a silver based dressing because it's a contaminated area, And for the bandaging, it shouldn't be bandaged tightly as it may compromise the vascularity of the remaining soft tissue.
Okay, thank you, Muya. So next question, how long will a junior surgeon takes to master this complex surgery? Okay, any of you want to share your experience?
For a pedicle flap, a junior surgeon may master it, but in terms of microsurgery, it needs a longer time, and it depends on the amount of the cases that are available in that center, and whether or not the training as a junior surgeon in a microsurgery is intense or not. So, does this answer the question?
Okay, Adzim, do you want to give your opinion?
I think in our training in USM before, as a registrar for third year and fourth year, we started to dissect this flap already, and this is one of the more simpler flaps to raise because of the very feasible flap planes. And I think with good guidance and good observation from superiors, it's quite rapid actually. It's very individual, but I would wager if you were to do this once a week, I think by a month you could raise the flap quite comfortably. Okay, and of course with more flaps you raise, there's more finesse and more attention paid to the respecting the blood supply. This takes some experience. So when you say master, that means a perfect flap. You mean maybe over the years to perfect it, I guess. But to just learn how to elevate it, maybe individually, I think maybe a month if you were to do it quite frequently under good supervision.
Okay, thank you, Adzim. Actually, latissimus dorsi is one of the workhorse flaps for plastic and reconstructive surgeon. Used to be, and either as a pedicle or as a free flaps. But nowadays, for free flaps, it has superseded by anterolateral thigh free flap because of its versatilities. But for the lat dorsi, it's actually quite easy to raise. It has a consistent anatomy compared to the ALT flap. So to master a single flap surgery for lat dorsi, I think probably, like Adzim said, may not take that long. But there is a lot of modification or planning details that you can do with a lat dorsi. For example, you can include other flaps surrounding it as a chimera, as a chimeric flaps, such as the serratus, anterior muscle together with a lat dorsi. You can raise the scapula bone to replace bony defects together with the flaps. Yeah, so it's that to raise muscular cutaneous is quite simple, but when you talking about making it more complex reconstruction, it's a good base for reconstructive work. Okay, we go to the next questions.